Hello students, in this third edition of Spotters and Boosters, I shall further discuss a few differentiating uh, points the sports and also as the learning areas. Now the answers to the previous homework on the Spotters and the Boosters 2 is given here. Question 1 was enumerate drugs that inhibit peripheral conversion of T4 to T3. It is not only propyl thiouracil but a number of other drugs such as amiodarone, propranolol, hydrocortisone, prednisolone, iodinated contrast media all can inhibit peripheral conversion. An intermediate acting glucocorticoid that lacks mineralocorticoid activity. It is deflazacort. Name a drug that is inactivated by red cell distress. Esmolol is an ultra-short-acting beta blocker used IV for hypertensive emergency and PSVT. Which fibrate is preferred to be used with rosuvastatin? Fenofibrate, not gemfibrozil, is used because it is least likely to be affected by hepatic uptake. It does not affect the hepatic uptake of the rosuvastatin, as it does not inhibit organic anionic transporter protein 2. Name a drug that is bound to red blood cells. Cyclosporin, tacrolimus are a few one. There may be many more also. Peripherally acting pure opiate antagonist used in post-operative paralysis. A newer drug, albumipan, mentioned dual agonist that acts on GLP-1 and GIP, which is developed as an anti-diabetic drug, injectable, and also for inducing weight loss in obesity. This newer drug is tirzepatide. It has already been FDA approved for both the conditions. Which PPI will you give to a patient on clopidogrel? I shall prefer pantoprazole or elaprazole. Pantoprazole is well-studied, established drug given orally and parenterally. It is given because it does not inhibit CYP2C19. Therefore, clopidogrel activation is continued. We shall go ahead with the edition 3. Objectives are same: to promote critical thinking, to crack MCQs, and enable IMG to select a particular drug as per the need of the clinic. Identify drug A and B based on their profile. I cause bradycardia and reduce cardiac work by beta receptor blocker. I also cause bradycardia and reduce cardiac work by beta blockade. So they are the common mechanisms. I am useful in angina but may worsen transmental angina. I am useful in angina and indicated during and after myocardial infarction. I am not preferred in diabetics on insulin. I may be used. A drug may worsen heart failure. B drug is a drug of choice as an important pillar indicated in heart failure. A drug is useful in thyrotoxicosis and migraine prophylaxis. B drug can be used but not well studied. I am useful in alleviating performance anxiety as well. B drug is not so. A drug worsens bronchial asthma and peripheral vasospasm, particularly in elderly. It is not in usual doses with the use of B drug. A drug reduces portal pressure in portal hypertension. B drug is not well established in this. Now looking to the clinical picture and uses, A appears to be propranolol with beta-1 and beta blockade non-selective, so causes bronchospasm and peripheral vasospasm and is avoided in diabetics. So if it is used in diabetics on insulin, it may delay recovery and cause prolonged hypoglycemia. Propranolol used to reduce portal hypertension as well. So B drug is metoprolol, perhaps a cardioselective beta blocker that lacks unwanted effects of propranolol. It is an important pillar of therapy of heart failure today. B drug can also be other cardioselective drugs, but these points are not given, clues are not given. It is not atenolol because atenolol is a water soluble and not used in heart failure. 4 beta blockers have been well studied in heart failure with reduced ejection fraction: carvedilol, bisoprolol, metoprolol succinate, and nebivolol. Each have characteristic features which are not mentioned. Second, identify drug A and B based on their profile. I am an anti-hyperglycemic with least risk of hypoglycemia when given alone because I increase insulin secretion according to the ingested glucose amount. I have only modest effect on normal glucose levels. B drug acts mainly on as anti-hyperglycemic by indirectly increasing insulin secretion with least risk of hypoglycemia when given alone. B drug inhibits a key inactivating enzyme in the mechanism of action. I am used parenterally once a week and now orally as well. I may be used alone or along with other antibiotics as a B drug is effective orally given once daily as an adjunct to other anti-diabetic drugs. The key point is a drug induces significant weight loss by suppression of appetite and producing satiety. Therefore, it is now indicated in the treatment of obesity. B drug is not indicated in obesity treatment and it is weight neutral. A drug is cardioprotective and reduces cardiovascular risks on long term. It also improves dyslipidemia. Such actions are not there with B drug, whereas it may actually increase risk of heart failure on long term. Other adverse effects are nausea, vomiting, diarrhea, risk of retinopathy with the use of A drug, and there is a risk of nasopharyngitis, cough, and diarrhea with B drug. These distinctive features would tell us to locate the anti-diabetic drug. It is not sulfonylurea because A is not sulfonylurea because it can cause dose-dependent hypoglycemia. But A drug can be metformin, can be ribaglinide, or can be GLP-1 agonist. Now, metformin acts on liver. It is not an insulin secretagogue. Ribaglinide is a shorter acting given orally, not parenterally. So these 2 points exclude these 2 drugs. The only drug which is here is semaglutide, a GLP-1 agonist used once a week for the treatment of diabetes and treatment of obesity. Metformin alone does not cause hypoglycemia. It is not an insulin secretagogue. So these key points should be considered in locating the correct drug. Other glutides could be there. I have not gone into that details. B drug is an enzyme inhibitor that acts like GLP-1 agonist. Is a DPP-4 inhibitor. It can be one of the gliptins. Now I have not gone into different gliptins. It is only sitagliptin which I focus because it shares many of the actions with GLP-1 agonist, but it is weight neutral. So gliptins could be the B drug and common gliptin is sitagliptin. It is not metformin or pioglitazone because they do not inhibit enzyme. They inhibit glucose metabolism, neoglucogenesis, and peripheral utilization of glucose is increased. So indirect release of insulin by DPP-4 inhibitors is the main mechanism that increases GLP-1 level. No weight gain, metformin may be weight neutral or it reduces weight, whereas pioglitazone causes weight gain. So they are and hepatotoxicity. So it is not pioglitazone. Identify drug A and B as a next exercise. A causes arterial current dilatation with little effect on heart rate. Some bronchodilation may occur. B causes bradycardia, reduced cardiac work, coronary dilatation, vasodilation, and bronchodilation minor. A reduces blood pressure in once daily doses. B reduces blood pressure in 2 to 3 times doses. A causes is indicated in the treatment of paroxysmal. It is not indicated in the treatment of paroxysmal supraventricular tachycardia, whereas it is the second choice for the treatment of paroxysmal supraventricular tachycardia, the drug B. A drug does not affect any way the sodium channel activity, whereas B drug may have some effect on sodium channel also, but the effect is minor. A drug has no role in thyrotoxicosis and migraine prophylaxis, whereas B drug have been used as an adjunct in thyrotoxicosis and migraine prophylaxis. Now it is less often used, but have been used. Typical adverse reaction with A drug is pedal edema, with B drug is constipation and bradycardia. A drug can be given with beta blocker, B drug cannot be given with beta blocker. In addition, B drug has a ability to inhibit P-glycoprotein in blood-brain barrier and GIT. Therefore, it may increase bioavailability and CNS entry of a few drugs. Now, if then A drug could be a dihydropyridine amlodipine long-acting, which is commonly used in the treatment of hypertension and causes pedal edema. No tachycardia is seen in usual doses because of longer duration of action. B drug is verapamil that always is a cardiac depressant and causes bradycardia. It has antiarrhythmic activity and is second choice for the treatment of paroxysmal supraventricular tachycardia. It is a potent inhibitor of P-glycoprotein and of course CYP3A4, so it exhibits a number of drug interactions. Drug B is not a beta blocker because beta blockers cause bronchoconstriction and they are not P-glycoprotein inhibitors. So we can locate the drug. B drug can be verapamil also, but B drug can be diltiazem also, but P-glycoprotein inhibition will not be. 5. Identify drug A and B. Drug A inhibits incorporation of iodine and tyrosine residues of thyroglobulin and coupling of these residues to form iodothyronine. So, A drug inhibits the steps for synthesis of thyroxine. B drug also blocks these steps in synthesis of thyroxine. Whereas B drug partially inhibits peripheral conversion of T4 to T3 by inhibiting deiodinase enzyme. But this effect is not seen with A drug. A drug is negligibly bound to plasma protein. B drug is highly bound to plasma protein. The A drug metabolism is decreased in severe liquid disease. It is not much affected with as for B drug. A drug is usually given once or twice. B drug is given 1 to 4 times daily. Rarely, severe hepatitis have been found with the use of A drug during pregnancy, whereas it is not seen with B drug. A drug. A drug may cause hypoproteinemia and bleeding, whereas B drug does not cause. It produces anti-neutrophilic cytoplasmic antibodies in 50% of users that may have a relationship with occurrence of syndrome, collagen vascular syndrome. A drug is usually avoided in first trimester of pregnancy because of potential embryopathic effect, whereas B drug is avoided in late pregnancy because of late liver impairment. So these features A drug to be methimazole or carbimazole that has longer half-life, higher potency, low protein binding and ability to cross placenta without any effect on the peripheral conversion of T4 to T3. B drug is propylthiouracil, shorter acting, less potent, higher protein binding, less ability to cross placenta and propensity to cause hepatopathy during late pregnancy. The last one is drug A versus drug B. Drug A inhibits rate-limiting step or enzyme needed for cholesterol biosynthesis, whereas drug B regulates gene transcription by acting on nuclear receptors. The characteristic impact on lipid profile is reduction in the LDL cholesterol and triglycerides, increase in SDL, Comparatively, B drug markedly reduces triglycerides and LDL cholesterol and some increase in the HDL. Both have a longer half-life, so given once daily. A drug can be combined with a fibrate, but when it is combined with gamfibrozil, there is a greater risk of myopathy. B drug can also be combined with the statin, and there is some risk, although it is less, of myopathy. Adverse drug effects are muscle aches and or myopathy. Myopathy, hepatotoxicity, skin rash are seen with B drugs. A drug is extensively metabolized and excreted through biliary route, whereas B drug is hydrolyzed by esterase enzyme and then glucuronidated and excreted. A drug may have no uricosuric action. B drug has a uricosuric action. So these distinctive features where A drug perhaps has a statin, it can be atorva and other statins, but characteristic features would be there suggesting their presence. Here, characteristic features suggest rosuvastatin, and the key feature is metabolism by cytochrome 2C9 and excretion hepatobiliary. Other features for atorvastatin are not present. B drug can be a fibrate. It is not gamfibrozil because gamfibrozil is shorter half-life and greater risk of myopathy with statin. So it is fenofibrate. Fenofibrate achieves greater triglyceride reduction and HDL cholesterol elevation than gamfibrozil. Fenofibrate can be given with a statin, particularly rosuvastatin, because it is glucuronidated by enzyme not involved in rosuvastatin glucuronide. Now, with all six comparisons, a little homework is given for your self-directed learning. And question 1 is an aminoglycoside drug used for treatment of amaurosis as well as visceral leishmaniasis. A nitramidazole drug effective against giardiasis and intra-abdominal anaerobic infection. An artemisinin derivative used intravenously alone for complicated falciparum malaria. An endo-ecto antiparasitic drug used in malarial control is, and the drug of choice for tropical. These simple questions you can find out from textbooks. A nucleoside analog used against HIV and hepatitis B viruses. A question is an antiviral anti-hepatitis C drug that directly inhibits RNA polymerase in hepatitis C virus. An antimalarial drug that kills hepatic hypnozoites is, and a vitamin D analog used mainly in the treatment of psoriasis, and vitamin A analog used for the advanced acne vulgaris. These questions can be found and it will prepare you for better presenting yourself at the time of Viva. And if you need, you can watch next edition of Spotters and Boosters for correct answers. Thank you.